Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I have Jacob and Alex. How are you guys doing?
Good. How are you?
Doing good.
Perfect. So if you guys could, Jacob, let's start with you. Kind of introduce yourself and a little bit about your point of view there.
So I came up here after my residency in family medicine. The unit just got back from Afghanistan, and we didn't know much about the cold. And then I've been up here for 4 years. I was a battalion surgeon, now a brigade surgeon, and kind of just got thrown into this. And now learned a lot of lessons, unfortunately, the hard way up here in the Arctic for 211 and previously 425 in Alaska.
Nice. Alex, how about you?
Been a medic for 16 years. Just got assigned up here about 2 years ago. It's my first time in Alaska. Noticed that there was no emphasis on medical training at all, and everybody kind of switched focus from coin in the Middle East to getting ready for Arctic conditions, and we really needed something. So we stood up this training center, Major Shook, to focus on getting guys ready for care in the Arctic because there was no emphasis on it before.
Yeah, absolutely. I mean, all of my combat deployments are all the Middle East, and coming from northern Michigan, it's a drastic difference, and you guys are even farther north than that. So I guess when both of you are kind of just thrust into this environment and their command is telling you, hey, figure it out, what problems were kind of blatant from the outset?
Frostbite was a big one, and cold weather injuries. Seeing it from guys doing PT to us doing field ops and out there. Environment's incredibly unpredictable and difficult, so it could be 30 degrees, it could be minus 30 and sometimes in parts of the year. And then adding airborne ops up here definitely adds another level of complexity that I've seen.
Yeah. How about you, Sergeant Strickland? What kind of problems are you running into?
Mainly just nobody focuses on training for Arctic conditions. So getting the guys who were evac patients, not even covered in HPMK, they were training like we were going to the Middle East, and they're just not wrapping them up. They're not keeping them warm. They're just trying to pass them off to the next person as fast as possible. So just trying to get them to slow it down and do the right steps.
Nice. So, and that's super typical of literally everybody, right? So, obviously cold weather injuries. I mean, I think we're all fairly familiar with those and what we should go about it. But you talked about using a sous vide for frostbite. Now, I've used it for steak. I guess I never thought about putting a human in a bath of water.
We developed that from a TTP we saw in an ER journal that someone was using a sous vide on there because in order to keep the water at 100 to 104 Fahrenheit, which is that golden of it's heating up the skin without hurting it, it's really difficult to do on a stove in a tent with, you're sitting there measuring with a thermometer, you're boiling water, and then it's too cold and it's too warm. And the sous vide is just a solution if you have electric that it does it all. It maintains the temps, it circulates the water, it's really a set and forget.
Nice. And you had good success with that?
Yeah, we've been using them now. 111 up north fielded them for their training exercise last year across each battalion roll one. Of course, power being the main issue, but it's an essential part of our kit now for all of our roll one and roll two assets.
Yeah. So, I mean, other than cold weather injuries, obviously you're going to be training for like T-TRIC, March, things like that, actual combat. How does that, extreme cold weather, how does that affect your ability to conduct March?
You want to take that, Sergeant Strickland?
Yeah, the extreme cold weather, just when we conducting March, like we're still going to stick with controlling the hemorrhage as fast as possible to tourniquet. We just placed hypothermia management immediately after, so we're trying to keep that heat before we lose it. So they immediately put them on a HPMK and get the sleep system ready to keep the patient warm right off the bat, because it's so much harder to get them warm again, if we can just keep the warmth in there. So that's what we preach. And also we have to worry about, getting the ice off the patient, the snow. So Major Shook, brought in the boo brushes and making sure that we get every little bit of snow and ice off the patient as fast as possible so we can get them dry too. So we don't just put them in HPMK and then have all that water melt and cause further problems.
Yeah. I mean, the HPMK on its own, like the HPMK and the ready heat on their own, they're okay even in North Carolina. They're okay in the Middle East as far as maintaining hypothermia. I imagine they must suck when it comes to, actual cold weather.
That's where we added on an entire sleep system where we're putting them in the HPMK in the sleep system. So you get your full layers, whether you look at the Alaska cold weather guidelines or some of the wilderness med journals. They talk about how to build a hypothermia wrap out of nothing. So you have your vapor barrier on the outside, which is your bivy sac. You have your insulation, which is your inside your sleep system. And then we have our reflectant material near the body on the inside, the heat source.
Nice. And are you able to maintain temperatures? I mean, obviously your casualties in training are not actually injured, so.
Yeah, and sometimes they get pretty cold laying out there in the snow. We do some trauma lanes, so we have to watch them, especially when the teams are learning. They're not brush as much snow off. They get snow in the system, and then your teammates are getting wet. But we have some awesome thermal that Sergeant Strickland got for us that you can show guys instantly, like, hey, look at the heat loss versus no heat loss on this side. And it's amazing, the difference.
Nice. So, obviously you're moving kind of the hypothermia management up earlier in the sequence. What about like airway interventions? I imagine, putting in a crike or something like that is going to cause some problems.
Yeah, it's the biggest example I give someone about the problems in the Arctic is airway. So let's assume that you have the dexterity and the ability to actually do a crike with the skills out there if it's minus 25 or minus 30 out. And then magically the tube is still flexible enough that, that you can work with. And then the balloon actually inflates and doesn't pop, because if you test the balloons in real cold weather, they become more brittle also. And then you have to find a way to secure it. The tape doesn't really work well. Some of your Velcro can get filled with snow. That's usually a problem if guys are dragging it around or doing stuff with it. So then you're trying to secure it. But honestly, if you put a definitive airway in, I still don't know what would happen if you bag someone at minus 30 with a definitive airway in. Is that going to cause flash pulmonary edema? Is it going to cause scarring on the lungs? Or is it just going to give them hypothermia? And the literature search has been done, and we just don't know.
Yeah. I mean, even the old, IV tubing trick we used to do as far as securing the airway, like that stuff would just snap in half, I imagine.
It depends on the cold. First Sergeant might be able to say some more stuff on that. I don't know how much he's done in the cold out there, but we've seen some things break you wouldn't expect, whether it was like plastic on rucksacks or even Cordura material, like a 1,000-weight Cordura break in minus 55.
Yeah. Do you keep your aid bag or your gear in some place like you can keep it warm enough that it'll stay flexible, or would that not even matter?
It's tough. I have some smart medics doing some awesome things. They're putting heaters in some parts of their aid bag. They're putting boiling water into a container, like a Nalgene, trying to keep their aid bag a little warm. But for light infantry, we're out there in the elements, so you're kind of SOL after a certain amount of time. If you're doing vehicle ops or anything else, you could probably keep some stuff warm, but it's going to get exposed to the cold. I went from the air to the ground, and between there and 10 minutes after, my ketamine froze solid. So it's cold enough, things happen pretty quick. But when you take it and, we have some guys using some Yeti containers, and they're putting heat packs in those, and I honestly picked that trick up off one of our medics. That I was like, man, this is really smart. Double-walled container, put a little hand warmer in there, and your meds are warm for 24 hours.
Yeah, nice. So, airway management, definitely going to be a problem. I imagine even just using one of the HME little filters that you would plug on top of it, that's not going to be enough to keep that airway warm enough so you're not running into issues.
No, I don't know of any other way. Are you guys doing first sergeant anything different on the air crews?
We had to add additional heating systems to the UH-60s and the limos and the mics that are up here to be able to actually just work in the back and make it so that it was actually tenable. So we've have to, heat is huge on air or ground.
Yep. So, I mean, if airway is a problem and I'm exposing this part of his body, like what about like respiratory problems? You're going on the chest, you're going to have to expose probably the biggest surface area of his body in order to actually work.
Yeah, how we're teaching it and kind of my philosophy is if you're going to put a chest seal on, which the chest seals stick very well down to incredibly cold temperatures, you might as well just dart them. We're going back to that second intercostal space that was initially proposed by TCCC, and then instead of going under the in the axilla, that way you can still access that. Again, it's easier to get up in here versus exposing down for that armpit slot for the third or fifth intercostal, depending on what you can get to down there. And it just seems like it's going to be another tough one. You're not going to be able to do a chest tube. You're maybe a finger thoracotomy, but you're really risking injury to yourself with the blood exposure there and exposure to the patient.
Yeah. Generally, you're stopping at, needle Ds as far as chest management.
Yeah.
Correct? Yeah. So going on to circulation, like you can't just start exposing arms and things like that to, negative 20, negative 30, negative 40 degree temperatures, because you're just exposing him to more frostbite or whatever the problem is. So how have you gotten around the circulation, or what techniques do you use to actually gain IV or IO access?
In the field, we're not doing much, right? So if it's minus 30 outside, you're just not going to get anything to happen. So what we're teaching guys is to really do that hypothermia care and get that evac plan started. Whether that's building a shelter, whether that's setting up some kind of tentage and getting heat in there, or getting them to a hard stand, depending on what the mission set is or where you're located. And then from there, you can go back into traditional March sequence, traditional treatments once you're in the warm. The only thing that we're really adding to that is making sure they plan for, okay, you've intubated this guy, or okay, you've put a IV in and you're running blood. How are you going to protect this as this guy comes out of this warm environment into the cold again for evac out?
Yeah. So I guess what kind of shelters are you bringing with you? I mean, as a light infantry unit, you're going to probably have some kind of organic shelter anyway. What kind of system are you using? Are you just improvising like wilderness medicine style, or do you have something pre-made?
So we have the Accio system, and I let Sergeant Strickland talk about some of that stuff too, if he wants to take this one.
Yes, we got the Accio, and there should be staged within a good little bit of distance, to get the patient back over there to a heated environment. We have issued life fighters tents, those small, pretty much one-man tents. The only difference about that from a civilian one is camouflage pattern. Like, we're really trying to get somebody to hopefully bring us something that is like an insulated tent work at it for like a small CCP. But right now, life fighter, and then hopefully Accio is already set up.
Okay. What are you using to heat those? With
tents?
The
10-man tent, we have the military issued stove tent, or stove runs off JP8 or wood. But with the light fighter, the only thing we've been fooling around with is like a buddy light heater, not a buddy light, my little buddy heater, which operates off butane. But if we can get like a solid fuel or a mixed fuel that doesn't freeze as well, but we don't have any of that yet.
Yeah. I guess how long for the smaller tents? I know those big 10-man tents, it can take quite a while to get those heated up to where you guys can actually work. Those small tents with that My Buddy heater, like, have you guys tested how fast it's going to take you to get to a reasonable temperature?
Yeah, I mean, it's my civilian setup is pretty much what we have anyways, but it takes maybe 2 minutes to get the tent at about 0 degrees outside. It takes about 2 to 3 minutes to get it nice and toasty in there. Like those things can pump out, and for a very small space, they can get it nice and toasty. But it's just finding the right fuel and finding an actual item.
Right. So it's kind of the scheme maneuver. You take a casualty, you're calling up ahead, hopefully for evac shortly, but you're probably going to need some kind of structure or shelter before that bird is able to get clearance, spun up, fly out there. So you're simultaneously calling ahead to have somebody set up a shelter, get it warmed up. Is that kind of the SOP?
It's very unit dependent, but that's what we teach is like, hey, light fighter, if you can bring a heating source for a small CCP, and then hopefully a 10-man tent, you already have it set up close enough by, or you identify an area where they're going to set it up to get a warming station while we wait for evacs.
Some of this comes down to, I think, are we doing some airborne operations, or are we staging and pushing ahead? If you're doing doctrine-wise, you'd be leapfrogging through those Akios, so you always have a warm shelter behind you to go to. If you're making contact, that's in another scenario, that might be a little different, where if you're taking sudden, unexpected contact, that'd be our concern, is now you have to figure out a heating system and where it's safe to put it up. And that's where I think the Arctic dilemma becomes even much harder.
Yeah, absolutely. I mean, luckily, weather is enemy to both sides as well. But another thing you were mentioning is like the meds freezing. Like, have you guys, you mentioned your ketamine froze. Have you unthawed it and used it?
Yeah, so there's some good studies we have that's been out there. It's called Meds in Extreme Environments. There's a link to it in that article we gave you at the bottom. And we've also done our own testing. Right now we have a little container out in our training area just sitting there with meds that we thaw and freeze. If it doesn't change color, if it doesn't have crystals, if it doesn't look like the viscosities change, usually meds are okay to go again. If you can find data on it, that's great. But if it looks good, it probably is from the most part. That's like the old adage. Example TXA, I've let that one go on and off. I have a few other vials of it, and we just had one that turned completely color and has crystals in it from like freeze-thaw cycles. So it's not just freezing or thawing, but some of it's good, some of it's not. Like lactated ringers is a big one. Once that freezes, it's not good anymore. Okay,
so you're just packing normal saline then?
Yes.
As far as crystalloids go?
Mm-hmm.
Yeah. I mean, have you guys, other than testing out, does this thing, freeze and thaw, I guess, and other, medics coming up with their own techniques? I mean, do you have some kind of like techniques you keep your bags warm, like you mentioned before, like specifically for your crystalloids, specifically for your meds? Are you kind of going back and forth between some kind of shelter and going out on patrol to try and keep my meds, as viable as possible for as long as possible?
Yeah, so there's a few answers to this. When I was in Cav and we were doing all the scout stuff, we were sewing pockets on the inside of our level 1, level 2s, and keeping anything we wanted to keep warm in there. A lot of us were wearing our chest rigs on the inside of our gear, so that way your radios and your other assets are staying warm with body heat also. It makes things kind of weird. You have a big jacket over your chest rig, but everything in there is staying warm. And if you need your radio to work, your Almar or something like that, that's the only thing you're going to have, or a way to do it. If you're in vehicles, I think that adds a little bit of flexibility with weight. Our Roll 2 has some med stasis containers. It's kind of like the Vaxi cooler, but for keeping stuff warm, not just cold, that they're using to keep their meds in between jumps warm. And I've seen a lot of guys be creative with necklaces, making a necklace around with their meds in it, or putting it on the inside of their gear. The only concern is if that stuff starts to leak, obviously you're in some trouble there.
Yeah, absolutely. I'm going to go on mission. I'm going to go somewhere into the Arctic. Okay. What kind of advice or pitfalls would you like to warn me about before we go?
Number one, and I'll turn over after this, in my opinion, is soldier tasks. So if you cannot properly operate in the Arctic, you're not going to do anyone anything good anywhere else, right? You got to be able to do those soldier tasks. You got to be able to move efficiently, understand your packing, get your gear right where you're not sweating every time you start off on a movement. They always talk about comfortably cool so you don't sweat, but really you want to be probably dang cold, and that way you don't overheat yourself.
Okay. Sergeant Strickland?
Making sure you know your equipment. So don't just go out there the first time and expect to have the equipment working properly, like big steps, baby steps. Just acclimate. Just like with any kind of environment we go to, you'd have to acclimate, test your equipment in a place where you can get warm real quick before you go out. PMCS of equipment, always incredibly important. And civilian items that you're not issued, if you can afford it and it's better, then it's going to be worth it in the long run. Like civilian hand warmers, civilian glove liners. If it's better than what's issued, it's best to float a little bit of money over it, and rather than get a cold weather injury.
Yeah, absolutely. First Sergeant, I'm sure you've seen a lot.
A lot of it goes into prior prep. Even simple things like aid bags, making sure your loops are bigger so that you can get to them and open things up with mittens on. Having spare redundancy for like your hands, keeping them warm, because you can't really do a whole lot with big old mittens on. So you're going to be taking those off, doing a quick task, throwing them back in, and you're going to lose shit. And so if you're not prepared and you don't do that prior checks and everything like that, then you're going to be fighting uphill.
Yep. So, you mentioned, gear. I mean, even when it's cold around here, the batteries don't last nearly as long. I can only imagine that there's a massive reduction in life of those batteries.
Yeah, you're looking at maybe half-life on batteries if they work at all for almost every single battery source you have in that cold weather environment. Like, they may not work at all, and if they do, you've probably got about 50% life at best. And they're not going to initially push out the power you need, so you lose distance on transmitting. You lose the ability on how hot they're going to get if you're warming something. Like, just everything decreases exponentially after like 0 degrees.
Have you noticed any, as far as medical gear goes, as far as, I don't know, like ultrasounds or monitors or things like that? Have they been able to hold up as long as you can keep power running through them?
Butterfly ultrasounds have worked. We've used them and jumped them, but they haven't really been exposed too much to the cold. It's more of a roll 2 thing. Sure. I think as long as we have power to them, we haven't had an issue with the butterfly ultrasounds that I know of.
Yep.
The EMA for CO2 works really well. I haven't had that yet.
Okay. Nice. I imagine like SPO2, anything that you're going to have to expose the soldiers' extremities, like things like that, are not going to work.
Yeah, that doesn't work. Also, the issue too is your O2 sats change with the shunting of blood away from your extremities to your core.
Okay. So how have you guys done SPO2 monitoring?
In a warm environment, and then I can talk. Let First Sergeant and Sergeant Strickland talk about how all these changes happen with. It's hard to recognize shock in the cold, so all those signs may not be there under hypothermia. So it kind of changes your car. You have to be a little more concerned about it, a little more aggressive looking for it.
Okay. I guess what are those? How does it change?
So in hypothermia, right, you're going to get that lower heart rate. You're going to get lower respirations. You may not even have any, depending on how hypothermic someone is, they may not have any heart or cardiac signs you can find, or respiratory signs. So they almost look like they're completely gone in severe hypothermia. So that with a shock picture, I think it'd be very difficult. I haven't got to see any of that. Seen some spinal shock in some pretty cold temperatures, but nothing that would be, some kind of massive transfusion-based shock of any kind, or massive hemorrhage, sorry. And I just don't know. I don't know what that really looked like. Some animal studies I think.
Yeah. I mean, I think, yeah, animal studies would definitely be helpful. Like it's just difficult all the way around. Like you essentially can do bare minimum things on the X, as it were. Then you have to travel to some kind of shelter in order to just really get your first assessment. It sounds like.
Yeah, it's just a bad day when it's really cold. Really, like you're gonna get your massive hemorrhage. You're gonna start aggressively treating for hypothermia. Maybe be able to do chest seals, needle D, and like move them out. That's really all we've got, right? I mean, there are some other things you can do, but for the main part, it is keep them warm aggressively after stopping bleeding and just move out and get them warm because that's going to be your definitive care.
Yeah, absolutely.
Yeah, I agree. I don't think there's any way to get it any faster out there in the cold.
Now, does the cold weather, we've been talking about how horrible it is, and I'm sure it is. Are there any cold weather benefits as far as shock and having that patient get colder, preserving that oxygen longer so that you hopefully can get to a shelter? Is there any truth to that?
It can freeze hemorrhages shut if it's cold enough or exposed, which can be a benefit until you warm them back up again. But I'm sure there is some protocol, kind of like the ROSC in a hospital of return of spontaneous circulation, where you put them in hypothermic management to preserve that. I don't know if that has a place in trauma or not. That'd be another great research field for someone to look at.
Yeah, I mean, it just reminds me of from the Napoleonic War, them talking about all the soldiers that would surround the fires. Those wounded soldiers would die. The ones that were pushed out to the far side would still be alive the next day. But yeah, I think you're 100% right. There's got to be some kind of research to that because they're going in the opposite direction of hypothermia management. Man, you really did not paint a very good picture. I don't feel good about my trip to the Arctic.
It's fun to go skiing and ice climbing and everything like that. And beautiful place to live, though.
Yeah. I mean, yeah. I got to be honest. You made it sound like it sucks all the way around. Yeah, I mean, is there any other tidbits that you'd like to add?
Not a ton. I think the biggest thing you said is the cold works for both sides, so understanding that's a big one. It really is going to be a war of attrition, so anyone you can save is going to be the answer. Knocking out those lines, knocking out those any kind of refills or anything you can get that's going to hamper the enemy, I think is probably worth more than actual initial trauma. Looking forward, though. Some of the concerns I have is going to be whether indirect fire on the cold. So if we do make thermal shelters that are CCPs, are we just making a huge hot target with any kind of thermal? So that's a big question I have, or is there a way around that? Or what was the best answer? Probably not digging a snow cave to be thermally hidden is not accessible in a short time. But yeah, it's going to be a tough one, I think, for us to figure out and continue to work on.
Yeah, I'm sure there's some kind of thermal camouflage that's out there. I mean, the Afghanis did it, and they used wool blankets, so there'd probably be some kind of answer like that. I don't know, Sergeant Strickland, do you have any tidbits?
Just making the guys get out there and do it, like not just waiting for your couple of weeks a year out in the field. Take them out just like you do a glass house at Fort Bragg, before you go to the range. Take them outside, get them in the snow right outside the building, and make them do the hard, tedious things that they don't want to do because it takes a long time and it's boring. But once you get out there and that life or flight kicks in and they know how to throw them in a sleep system super fast is what's going to save lives. The simple things are what's going to save lives because there's not much else we can do really right now.
Right. You're 100% correct. And that point comes up over and over again. It's the basics that save lives. being able to do the small things rapidly in really whatever environment you're working in is what's going to save the day, not the advanced trauma procedure. For Sarn, do you have anything else you'd like to add?
I think just for this environment, you have to make the decision to transport early. So if you're looking at taking somebody back somewhere to warm them up, you usually need to be looking for that definitive care. Whether it's ground or air, you got to be.
Yep. Perfect. Well, thank you all very much.
Thank you.
Thank you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.